Rudi Campo for coming and giving this lecture in this really very special occasion for our clinic. Rudi Campo is really very well known endoscopist throughout Europe. Actually, he was the president of the European Society of Endoscopic Surgery until recently. He is now the past president. He is member of the board of the European College of Obstetrician and Gynecologists, and he is currently the director of the European Academy of Gynaecological Surgery, and he is the director of the IVF unit in the Genk hospital in Belgium. Rudi, thank you very much. Please, thank you.
Thank you very much, Grigoris. Ladies and gentlemen, it is a real honor to be here, and I'm very sorry, but I do not speak one word of Greek. I had it at school, Old Greek, but it is not my specialty. My specialty is endoscopy. And I will share with you some new borders of the hysteroscopy. If we say beyond the frontiers, we do not mean perforation. Beyond the frontiers, we mean that we go and look for new adventures from new areas. And the reason is that nuclear magnetic resonance imaging has learned us that the uterus is not only a muscle with some endometrium, but that the uterus is divided in three functional areas. The endometrium, but then the black, that's what is very interesting. That's the junctional zone myometrium. And the difference between the black and the gray, you cannot see in ultrasound, or not like here. It's a difference because the function of the cells is different. Both are muscles, but the function is different, and what is interesting for fertility and abnormal uterine bleeding is this area. Now, this area, exploring by laparoscopy would be very stupid, because the way of access is here. Here you see total loss of function. You don't get pregnant with this. Focal adenomyosis, a focal change in which you have pain, bleeding abnormalities, and eventually infertility. So today, the challenge is that we have to give an answer to every woman suffering from bleeding or infertility, the capacity of their organ, the capacity of the womb, the incubator, the organ which should carry the child. And we cannot do this by hysteroscopy alone. We cannot perform an MRI in every woman, and we cannot do this by ultrasound alone. We need ultrasound information, we need the interior information, we need contrast information, but we also need the biopsy, tissue sampling, anatomopathology, and eventually we need minor surgery to get tissue and to know what is going on. This is what we call the diagnostic procedure. And then we have the real surgery, the hysteroscopic surgery. If you see 3D ultrasound, and as the director of the clinic showed us, beautiful instruments, beautiful images, a lot of information, but not enough. If you see hysteroscopy, the cervix, the cervical canal, the tubal ostia, beautiful images, but not the total content of information. If you do them together, you have ultrasound 2D, you see myoma and polyps. And the subtle lesion, whoop, the precursors, the mucosal elevation. So two totally different groups of population, which reflects the pathology also in those small lesions. So now how do we do it? We need new instruments, because to do what I showed you what we should do, the current instrumentation does not fulfill the task. We need, we need a scope. It's an all-in-one scope, no shaft systems. You have a very automatic tip, and then you can put accessory sheets. If you put the sheet, the diagnostic one, it comes until there, and you have 7 centimeters of free room. If you put it forward, you get double flow, but you can also do a DNC. You put this here in, you take out your scope, and you have a DNC. So you can do a DNC without putting a speculum, without traumatizing the patient. So, passive situation, You have the smallest possible hysteroscope, and we know that size matters in hysteroscopy. In hysteroscopy, size matters. It is absolutely a difference, a 5 or a 2.9 millimeter instrument. It's the difference between killing a woman and having a friend for life. You put it forward, you get a progressive atraumatic dilatation, double flow, and you take it out. You can put a DNC cannula, and you could put a new instrument which is called the spiratome for myometrial biopsies. So here you see we are doing the DNC, but after the DNC we go and look. We know what we've done, because you have a double flow instrument. This atraumatic sheet stays inside, and we do not have to put a speculum, and we can exactly see if we have taken the tissue from the area we wanted to take. Here we are back again, MRI. Now here you see in ultrasound that this white zone is something peculiar. So we need a biopsy there. How will we do it? We can ask professor to do a laparoscopy, but then he will take the whole womb. It's not what we want. We want from here atraumatic, without anesthesia, without pain, to do the job. So what do we have? We have a corkscrew, and with a cutting device. And as you see in MRI, the posterior wall is total loss of function. So we'll take 2 biopsies, and now we are turning into the wall the corkscrew, and we go until the serosa. But we see it in ultrasound. And only when we're 100% sure, we make the cut. Does it hurt? It hurts a little bit. Every cut hurts a little bit, but we inform the patient, and it is absolutely tolerable doing this without any form of anesthesia. And we did it twice, and I will show you the results. So those are the samplings in breast biopsy using the same technology. So very, very long tissue samplings. And here we have done 2 samplings, and if you see the corkscrew, the cutting device under hysteroscopic vision, and if you know that this is 1 centimeter and you measure the thickness of the wall, and you know the wall is 2 centimeters, there is no risk. You can make your cutting, and you have an absolute perfect sampling. And when you take it out, it does not bleed. We do not understand really why it does not bleed, because it does not bleed with fluid, it does not bleed if it lower the pressure, so it is a really atraumatic biopsy. And they use it for heart biopsies, for bone biopsies, and for breast biopsies, and it is a very, very, very interesting technique. But if we want to do some surgery, so we have now tissue sampling, but now we need to remove something because there is something. It is debatable to do this without anesthesia, little bit sedation, but some do it without anesthesia. But here we see a little myoma polyp, but here the tubal ostium, a little hole here. So those subtendines, we drop the pressure and we see some vessels. Now let's explore this area. Let's go and look carefully. What do we see? Chocolate. Belgium chocolate. No. Real chocolate. The chocolate dye which you see when you open an ovarian endometrioma, it's just the same. We look inside and we will remove the tissue here because we need the full, it's pathology. We need to dissect, we see the aberrant vascularization, and carefully under vision we have to dissect. And if we dissect, you see how deep we go? We go very deep, but no problem. You have to be skilled, of course. But you have ultrasound guidance, and you do not do anything without correct visualization. Now, in the same woman, we find another cyst. She has a lot of cysts, so we have removed one for pathology, and here we use a special bipolar probe, and we will coagulate the whole surface. And now we look at the results. After 3 months, she got drug treatment, GnRH analogs. That was the MRI. You see 1, 2, 3, 4, 5, 6 cysts. They were treated, and we see that independently, if we do coagulation or cutting, we have always remaining areas where we have done the surgery. In contrary to the myoma, adenomyosis is a disease of the muscle, And if you cut a muscle, you will have always a residual lesion. So be careful, you can have adhesions. Now, two new frontiers, the dysmorphic uterus and then the real adenomyotic surgery. First of all, yes, this is Grigoris Grimbizis from Thessaloniki. This is the new classification from the world, ESGE, ESGE. We beat the Americans. And with a lot of work, but thanks to the guide, Grigoris, a new classification is established, and it gives us the possibility now to classify anomalies which previously were not classified, and supplementary, which were thought to be of no importance. And that is this, we go from normal to absence. But these subtle lesions, those little cavity deformations, what does it mean? Does it have any significance? This kind of malformations. Again, you do ultrasound, you see in hysteroscopy, you don't see the tubal ostia, you just see a small way, and then in contrast, in the coronary plane, you see very clearly that the lateral walls are thickened and that we have a problem of a T-shaped uterus. We did a prospective registration, and what do we see in an infertile population? We see people with septated or T-shaped uterus, and all the other malformations we neatly do not see. 1/3 T-shaped and 2/3 septated. This seems to be important. Now, if you do the treatment, there are a lot of techniques, but as I'm a microsurgeon, I like to do it in a very gentle and a very anatomical way. So we just cut. We do not remove anything. We don't use electricity, only with the scissors. We cut and we make the normal, it's plastic surgery, normal pear shape-like pattern. So you see, under vision, you take a scissor and you look at the fibers. Normally, there should be blood, because this is the womb. There you need implantation. You need a healthy vascularization for implantation, and it is not there. So it could be of importance, and you have there, covered behind this little piece of tissue, you have the tubal ostia, and you make a straight line until you have the vessels, or until you have a correct anatomical performance. If you have in the midline also a thickness of the wall, again here we cut. And again here you see that there are no vessels. Until today we do not know what is the cause of this small malformation in relation to miscarriage. We cannot explain it clearly. There are a lot of theories, but one of them is that the absence of vessels would disturb the implantation and the growth of the conceptus. But we do not know if it's correct. There we see the vessels are coming. And the aim of this surgery is to get the ostium, a straight line to the other side, a straight line downwards, and here we have the anatomical proof of a normal uterus. Now, is this a game? Should we do this? Are we helping the clinic director to earn a little bit more money? Or do we have something which we should treat? We have the first more than 100 patients. Well, actually, I know there's another group who has 115, but they did not publish yet. And from 100 patients, we have now 73 who became pregnant. And we see that 17 did a miscarriage. No ectopics, but 17 miscarriages is still a little bit high. But from all the others, we have ongoing pregnancies, and until now we did not lose one baby. We had 95% of the deliveries at term. In a population where they did not have babies, only miscarriage or preterm deliveries, and lost their children. Interesting. Now, what are the complications? Intraoperative, none. I'm a champ. But afterwards, we see that we have some adhesions, but they all got pregnant, but we had to treat them. And 3 abnormal placentation. Placenta retention, I do not know if there's some here doing obstetrics, but if it starts bleeding, this is really, really heavy. So 1 patient, intensive care, and nearly died. There was one at 36 weeks. So we have to be careful, and we have to inform the obstetricians on this risk. There are 239 publications, and there's only 1 study of Fernandez of 97 cases, and Garbin, Aubriot, and Baranger very likely have cases which are in this study. But this we cannot prove. Now, if we see our results and compare with the literature, then we have 100. That was the aim. There are 2 reasons we go to 100, because it's easier to count if you have to calculate the percentages, but also we wanted to beat the French. So we have 100, and we have 73% with a mean time to pregnancy of 3.4 months. That is strange. We have a lower miscarriage rate, but it's certainly not significant. But we have a significant higher baby take-home rate or term delivery rate. And there are only 2 differences between the groups. One is that in this group, still death hormone T uteri were present. In our group, none. All natural T uteri. And the second is that they use the resectoscope, big instruments, and electrical current, and we the small hysteroscope and only the scissors. And the group in Valencia, who is using the same technique as we do, have 115 now. And they have just the same leverage as we have. So I think that the surgical technique will probably be the most important one. And now, last but not least, adenomyosis. Who knows what is adenomyosis? Everybody? We have the womb here, we have a little hole here, and we see here the big cyst. Adenomyosis is one of the main research topics of the Professor Grigoris Grimbidis, and I'm sure he will make also here a new classification. If you go into this lesion, you see it is just like an ovarian endometrioma. Now, here we are in the womb, not in the ovary. So you have the possibility to coagulate. There is also for the ovary. I was at Kogi, Paris. There is an absolute recommendation, also in the ovarian endometrioma, not to strip anymore, but to coagulate, but carefully, because you lose the whole cortex if you take it away. And your AMH is... So we did this, and you see how deep we came with coagulation. Now we look at this woman 6 months later, because it did not work very well. She did not get pregnant. And what do we see? Look carefully. The ostia looks a little bit red. The ostium, no polyps anymore. And we see here the little defect, but actually it looks very nice, except for this protrusion, which you will see here. Okay, now let's have a look. First we look in the upper part, and we see if we drop the pressure, too many vessels. An embryo cannot survive here, we think. And so let's explore this. The blunt scissor, there is no risk. And if Belgium chocolate. And what does it do in the womb? It induces the immune system. It is irritating blood in the muscle, and you get all the immune competent cells coming. You get the hypervascularization, which is a sign of an immune process, and she will not get pregnant. Now here, the question is the same. Is this normal? What is behind? What is behind the curtain? There is no cyst because we cut, it's solid tissue. Second question, if I cut, will it bleed? Because adenomyosis, neovascular, it bleeds, yes, thank you very much. So here we need coagulation. And look at the vessels. This is under the endometrium. This is neovascularization. wherever you cut, it starts to bleed. This is not the healthiest soil to get pregnant. So we have to remove this. And it has been shown by several publications that if you do not remove adenomyosis with drugs, you don't get the result you need for a healthy pregnancy. Now we take the resectoscope and we will resect. And this is real surgery. And we resect into the myometrium. It's still even more difficult because behind this area, there's silicysts. So you have to find this. Let's go and look. And this is the advantage of hysteroscopy. You see exactly if it is okay. You can recognize, but if the whole muscle is diseased, then you have a problem. Yeah, so check. Your safety zones should always be 5 millimeter, and here you will see that here is something which is a little bit, so we coagulate. This is okay, and now here we have to find it. You see the surgeon, which is me, but here you see it, the bulging. So we decide to cut here, and we decide to cut further, and we got it. Here, this is blood in a cyst, and if you don't have this, you've done nothing. You have to remove it. And it will bleed because it's adenomyosis. You've seen the vessels, how big they are. So you need a good instrument which can counter, and you need to remove exactly the wall of this cyst, which is technically not so easy. So this is microsurgery of the womb. This is ambulatory surgery. The patient leaves the facility 1 hour after the surgery. But you need high-tech instrumentation, good organization, and a good team. Not only the surgeon, the nurses, very important. Job done. Last but not least, the frontier is the endometrium. No, the frontier is the myometrium, the junctional zone. This is a myoma. If you go inside, you go with your scope behind and you can remove it totally. Now we go to the adenomyoma as a last example of myometrial surgery. Here you see this tissue. And if we go to the tissue removal, you see the vessels. Again, this neovascularization, pseudocapsula, all with vessels. So here you really need to know what you do. Because if you cut like Harry Cowboy, then you become barbecue Harry. You coagulate everything and it's ruined. You really have to be very careful. But at the end of the surgery, you see at the lateral wall, we removed the adenomyoma, which is muscle, but diseased muscle. We removed the adenomyoma, and we have a huge crater, but apparently we helped the patient, because she got pregnant afterwards. But it's no proof. Science is different. You need a lot of cases, and we do not have so many cases. So, ladies and gentlemen, I hope you enjoyed the show, but the message is that with hysteroscopy, ultrasound, and anatomopathology in an ambulatory environment, you can give answers which cost a lot of money if you use other instrumentation. It's a new world is breaking through. We have to treat the subtle lesions in the uterus, both for the cavity deformation as for those little signs of subendometrial pathology. And for those who are very interested in endoscopy and a look at all the nurses, then come to the next Congress in Budapest, Building Bridges, 7 to 10 October. It's fantastic, and we have a special nurse program. Just ask the director if you can come. Thank you very much.
So, Rudi, thank you very much for giving us this really very interesting and splendid lecture. So, we have Rudi Campo with us, so we have the opportunity to have questions. If anybody wants just to make questions, comments. Yes, Nikos Papadopoulos.
I want to ask you, these last cases that you showed to us with the adenomyoma and the scolectic cyst, do you use, as the previous cases, the ultrasound scan at the same time? Because, okay, you can measure the thickness of the uterine wall, but still we all have the fear that we will perforate.
So ultrasound is an absolute necessity within the operative theatre. You don't need laparoscopy, you need ultrasound for this kind of surgery. I do not need, in most of the cases, I do not need simultaneous ultrasound because I make my surgical strategy when I've done the ultrasound previously. But in any case, and also for me, if you're not sure, if you need to reach an ultrasound recognizable target, obviously you need ultrasound, you reach the target, and then you continue. Simultaneous ultrasound has two drawbacks. Doing it rectally is very uncomfortable. Transvaginal is not possible because you're already with the scope in the vagina. And transabdominal does not give always the same nice images as the vaginal probe. So sometimes this is the drawback of simultaneous ultrasound. So sometimes we go out and we do the ultrasound transvaginally to be very, very specific. And for example, in Asherman, if you have to go to one specific spot in the cornua to find the pathway, you do it under ultrasound or with the trophy hysteroscope. So yes, you need an ultrasound in every operative theatre where you want to do this kind of surgery. Please, but in English, please.
I'm Dr. Katerina Karavida. I'm actually a maternal fetal medicine person, not an endoscopy person. But I would have the same question as with my colleague. But why is it not possible to do simultaneously your procedure and transvaginal ultrasound if you adjust for a vaginal problem that will allow you to move and do the surgery?
It's very uncomfortable because you have conflict of two instruments. So if you do it transrectally. The vaginal probe is in the rectum and the hysteroscope is in the vagina. And some people do it, but it's a little bit dirty. We don't like it.
Consider that for the patient that is under anesthetic?
Sedation, yeah. The conscious sedation they get. Transrectal without conscious sedation is not very comfortable.
Yes, Kalogiannidis. Yeah.
What's your experience concerning the rate of asthma syndrome after the surgical intervention of steroid? Do you have any rate?
Yes, I have. It depends on the pathology. If you have placenta remnants, the incidence of Asherman is up to 66% when you do the second DNC. So in our facility, no second DNC. Every second DNC is done by hysteroscopy. In cases of ablation, you have a lot of adhesions. In cases of myomectomy, you have up to 44%, but we proved that this is due to the wrong technique. So with a correct surgical technique, we have with myoma resection less than 1% of adhesion formation. And then in all cases where you have adenomyosis, you have a high risk of adhesion formation. So it is technique and pathology which defines. And then you have the pregnant uterus, which is very sensible for adhesion formation, and the non-pregnant, which is related to your patient, pathology, and surgical technique. Yeah.
So you think that it's more related with pathology? More related adhesion?
Yeah. Three things. Genetics, the woman, if you are from Israel, or the African woman, there are more adhesions. Secondly, the pathology, adenomyosis. or the pregnant womb, placental remnants, high incidence of adhesion formation. And third, the surgeon, barbecue Harry, a lot of adhesions. Microsurgeon, less adhesions. And then you have the last is that today we use a lot of barriers, hyaluronidase barriers, to reduce adhesion formation in high-risk cases.
Yes, Spiros.
I'd like to ask until which size you should take out some adenomyosis nodule? Until which size?
Yeah, that's a very good question, and the answer is I do not really know, because we do not have, until today, we do not have the proof which of the pathology is really important and which is just diagnostic. So the strategy we follow is that every pathology which has a relation to the uterine cavity, we should remove. The pathology which is really like the intramural myoma, we do not know. The studies say intramural myoma, 5 centimeters, plays a role, but when it's small, it does not play a role. But we know that the submucous myoma with cavity position always play a role. So this we should remove, and we do the same for the adenomyosis. If it's small or big, we don't care. We remove it when we have a relation with the cavity. Now, more and more, based on the studies of laparoscopy and major surgery, where you really remove the 4-flap surgery, where you really remove all the as much as possible, you see that it improves. So now also with hysteroscopy, the size does not matter too much. A big cyst or a small cyst, for a myoma it matters a lot, but for the cyst not too much. And then we try to remove as much as possible also the deeper layer, but it's a little bit tricky. It's not starting surgery.
So any other questions, comments? So I would like just to make a comment. I think that we are thinking until now that hysteroscopy is really a simple procedure, and it's actually simple, but you have to be a little bit trained on that. But the most important thing after this really very nice lecture is that using this tool, together with ultrasound, you could improve your results, your clinical results. And this is, I think, the most important message from Rudi Campo's lecture. And for this, I think that actually Rudi did a lot of job. I mean, just giving us the opportunity to see two new pathologies and new ways of restoring, let's say, fertility and also, other gynecological problems. So thank you very much indeed for coming with us.
Pleasure being here.
And it's really very nice to have such lectures to this audience.